everyone. Welcome to our webinar, When is it Fibromyalgia? Diagnosing Chronic Pain Conditions. I'm Nicole from Swing Care and really looking forward to chatting today with our guests, Dr. Jisna Paul and Dr. Andrea Chadwick. And one of the reasons we have this topic today is so many patients with fibro, I've seen multiple doctors and different specialists even to just arrive at a diagnosis. And so today we're going to talk across rheumatology, pain management, and specialty fibro care to learn more about how fibromyalgia is classified and why, and really what goes into that process of diagnosis and treatment. So really excited for this topic today. And just to share a little bit more about our guests, we have Dr. Jisna Paul, who is a clinical rheumatologist and associate professor of internal medicine at the Ohio State University Medical Center, where she is also director of clinical operations for the Division of Rheumatology and director of the Musculoskeletal Ultrasound and Myositis Clinic. Besides clinical care, her research efforts have been centered on therapeutics and rheumatology, and she also serves as the PI for several myositis trials. So really excited to have you here today. And also with us is Dr. Andrea Chadwick, who is medical director of Swing Care, a specialty clinic dedicated to fibromyalgia treatment. And she is double board certified in anesthesiology and pain medicine. Her clinical expertise focuses on complex centralized pain syndromes, including fibromyalgia. And she's also director of the Fibromyalgia and Centralized Pain Exploration Lab at the University of Kansas Medical Center. So that's a lot of expertise that we have in this room. I'm really excited. And as we jump into the discussion, I just wanted to start by talking about fibromyalgia and its pathophysiology, or kind of what happens in the body when someone has fibro. So Dr. Chadwick, can you kind of start off giving a little bit of background on that and kind of what's known today?
Absolutely. So what we know about fibromyalgia is it's a chronic centralized pain condition, or something that's actually been dubbed by the International Association for the Study of Pain as nociplastic pain, meaning it's pain that is arising from not a peripheral issue and not from a nerve or central nervous system lesion. And that's distinctive from what we know is causing fibromyalgia, which ultimately is a variety of different processes that cause the central nervous system, which is the brain and spinal cord, to be sensitized to pain. It's multifactorial, as I've mentioned, but amongst all of these different causes, we know that there are a variety of risk factors, things like stress, infection, other types of autoimmune or rheumatic diseases. But ultimately, it leads to widespread pain and other associated symptoms like difficulty with sleeping, fatigue, and what we colloquially call fibrofog, which we could describe as like cognitive difficulties and other types of cognitive problems.
Got it. And, many people with fibro often get sent to someone like Dr. Paul, a rheumatologist first. And so, why is that? Is fibromyalgia similar to other kind of autoimmune or rheumatic conditions that are treated by a rheumatologist, or how does that kind of show up?
Fibromyalgia is not an autoimmune disease or an inflammatory disease. I think the practice of sending to rheumatology might have started because rheumatology deals with joint pain, and a lot of our diseases can present with similar symptoms. And another reason I think why it is still continued, I think, is because a lot of autoimmune diseases can overlap with fibromyalgia, and it is important to rule out anything else that might be going on in addition to fibromyalgia. That is the reason I think rheumatologists get to see more fibromyalgia, and we see a lot of patients with chronic pain anyway, and a lot of specialties can manage pain, like Dr. Chadwick here. So it doesn't need a rheumatologist to take care of fibromyalgia, but it won't hurt to initially see and diagnose and all.
So in that type of appointment where a patient is coming to you with, let's say, joint pain, but also kind of other widespread pain, what is kind of the process that you go through with the patient to determine, okay, is something else going on?
So each disease has, in the autoimmune inflammatory world, it has its own way of presenting. Even outside the box, we can still see a pattern. And so we try to find if that fits one of the diagnoses or not. Whereas fibromyalgia is mostly, the hallmark of fibromyalgia is diffuse pain and usually not joint-centered. It is more muscle and joint and everywhere. So the diffuse pain is the hallmark, which is not common for many other rheumatological diseases. So the presentation, the history, and the exam findings, and sometimes the labs being the last one, helps us to diagnose a particular autoimmune condition.
Ultimately, we've talked about some of the diagnostic criteria for fibromyalgia. It's that widespread diffuse pain, very muscle centric, can include the joints. There's also the potential for kind of vague neurologic type symptoms where they might get pins and needles or numbness sensations that are transient or can migrate around their body. But I'm also looking for those types of pearls or clues in the history and physical exam that might lead me to believe that something else is going on. So one of the major changes they made to the fibromyalgia diagnostic criteria in 2016 is that there is the possibility that fibromyalgia can exist with other disorders. Previously, the diagnostic criteria said, do you have a disorder that would otherwise explain the pain? Well, what we know about fibromyalgia now is it's a yes and condition, potentially, meaning patients can have other coexisting disease. So I'm always looking for those little clues in the patient's history or things on physical exam that might make me think that it's either an autoimmune or a rheumatic condition or inflammatory condition versus a possible neurologic condition. I've seen a lot of other things that have been written off as fibromyalgia that present in a different pattern than I know fibromyalgia should be presenting with. Whether it's a patient showing up in a wheelchair telling me that they're very, very weak to the point they can't walk, that's not fibromyalgia. We need to get to the bottom of that. But in the terms of autoimmune, which is I know what we're talking about today, I've had patients give me little clues about their history, whether it's a rash that's shaped in a butterfly on their nose, or symptoms of Sjogren's, which are dry eye and dry mouth and other associated symptoms, to patients who've had some very strange kind of eye disorders, something called uveitis. All those little things that patients tell me, I listen to, and sometimes it's like putting a puzzle piece or a puzzle together, trying to listen to all these different pieces and see how they arrange. And I have a pretty low threshold to run labs on patients, just a general panel, an ANA, some of the other inflammatory markers. But if they have these other symptoms that may not be as suggestive, we do know, as Dr. Paul was mentioning, sometimes there are these, seronegative or other types of syndromes that can arise that are inflammatory or autoimmune. So I really rely on my expert colleagues who are, in our rheumatology clinics here where I practice to be able to help me fill in those gaps.
Thank you. And yeah, I know you mentioned ANA and some of the other kind of labs in the panel that you often look at. Dr. Paul, maybe starting with you, what are some of those labs that you find very helpful to kind of either ruling out other conditions or kind of getting closer to a diagnosis when someone is presenting with fibromyalgia-like symptoms?
So fibromyalgia per se, it doesn't, we don't have a test which is very reliable and has high specificity or for fibromyalgia, but we do run other tests depending on the patient's presentation. So if we are suspecting more like a lupus-like situation, we run anti-nuclear antibody, which is the ANA test, which is also a non-specific test, but we also seen in a lot of autoimmune conditions. So if someone has a positive ANA, we may get more alerted towards lupus and other autoimmune conditions. So likewise, if we see more joint symptoms and with the classic findings of rheumatoid arthritis, like I described, we run the rheumatoid arthritis test, which is rheumatoid factor and CCP antibody. Almost all patients, we run inflammation markers, which are SAD rate and CRP, the C-reactive protein. Because if the inflammation markers are elevated, it could suggest an underlying inflammation. So those are our usual labs. So ruling out rheumatoid arthritis, ruling out inflammation, ruling out ANA, and sometimes based on other unique symptoms. For example, if the patient has a rash suggestive of psoriasis, we would consider psoriatic arthritis. Or if they have a lot of low back pain, we would think about spondyloarthritis. So we may run X-rays to diagnose that. And very rarely, if the patient has muscle weakness in addition to muscle pain, we may think about something like myositis. So it all depends on how they present. Of course, we are not giving the entire autoimmune panel to everybody who come across our, that won't be efficient use of our resources. That is where, like Dr. Chadwick mentioned, having trained eyes can be helpful to decide which all tests needed in a particular patient. And she's very much right. We have a lot of patients with overlap of fibromyalgia with other conditions. They can just run parallel together. So we have a lot of lupus patients who also have fibromyalgia. We have rheumatoid arthritis patients who have fibromyalgia. We have myositis who have fibromyalgia. So it can overlap too. So it's important to identify both of them because the treatment is different for each conditions. Yeah.
Thank you. Yeah, I feel like there's so many different things that patients kind of talk about in terms of trying to identify like where a particular symptom is coming from. Like, is this coming from my RA or is this coming from my fibromyalgia? And Dr. Chadwick, I'm wondering, when you have someone who does have those overlapping conditions, how can a patient know if they're experiencing a certain type of pain, like what treatment to proceed with, or I guess how do you know as the physician?
I mean, that's the $1 million question. If I could ascertain what body part, what pathophysiology of that body part was causing the patient's symptoms, that probably wins some sort of major prize. But what I would say is, one of the beautiful parts I've love working with other clinicians is I learn so much from my colleagues and understanding, when an autoimmune or rheumatic disease is under good control versus when it's having its own flare, because fibromyalgia can have flares, but rheumatoid arthritis can also have flares as well. And so really it's distinguishing what are those typical classic features of the rheumatic or autoimmune condition. So in the case of rheumatoid arthritis, are they having active joint swelling, redness, mobility issues, indicating high levels of inflammation? You would probably want to check labs, things like that. And again, I always work in tandem with my rheumatology colleagues in those instances where we're not quite sure what's causing what. But typically speaking, if the pain in that region that the patient is having flared, or if it's really widespread and they're having a flare of everything, that's more likely to be their fibromyalgia. Let's say they are that RA patient, but their joints aren't swollen. There's no redness. The inflammatory markers are great. They're not showing evidence of active ongoing inflammation, again, indicating that rheumatoid arthritis is under good control with whatever medication regimen they're using. Then I would likely say, okay, if the pain in that region is severe, but we're not seeing those signs of active inflammation, then we're probably going to suggest that that's fibromyalgia. And I really do lean on my colleagues, especially for some of these seronegative, autoimmune conditions like Sjogren's or lupus, where you're not going to see that crazy inflammation you would see in the joints with the RA patients, to really say, hey guys, are we dealing with is this lupus not under good control, or are we dealing with Sjogren's or a myositis? And a lot of times my colleagues are really great at seeing those patients, determining if anything needs to change for autoimmune management. And if they really feel that's under good control, saying, hey, I think it's just the fibro. But that's a very great question. It's very hard to determine, but I think those little tips and tricks of understanding what constitutes that autoimmune condition, what are those classic features, what do they look like when they're actively in disease versus what we know about fibromyalgia, it can help you make that distinction or delineation.
Yeah, and I feel like, you're talking about your colleagues. I feel like as a patient too, it's so beneficial to get access to a clinician like both of you who see a lot of fibromyalgia patients so that, like Dr. Chadwick, you said, you can kind of get those pearls that like a very trained and familiar eye can understand. That's very hard to kind of pick apart.
Diagnosing autoimmune conditions are most of the time just like solving a puzzle. So you get bits and pieces from maybe it's from history, maybe from exam, maybe some from the lab. So that all helps. And one thing which always helps us rheumatologists a lot of people have pain, but what makes a pain inflammatory is if they have a lot of stiffness when they get up from rest. Most people being at rest in the night. So when they get up in the morning, if they have a lot of stiffness and it is joint specific, that points more towards arthritis. Whereas in fibromyalgia, there's no pain pattern like that. It's almost all the time, it's very diffuse. So that is a very helpful tip.
I would say not only is it diffuse, but it migrates. And so
Yeah.
one week it might be the knee, another week it might be a hand or the wrist. And so oftentimes in those arthritis conditions, it's not going to change much.
And what about, there's a symptom that a lot of patients describe that's kind of like that tingling or trying to put it into words, but yeah, that kind of like tingling feeling. Dr. Chadwick, maybe starting with you, like where does that come from? What is that? And then is that specific to fibro or is that overlapping maybe with other conditions as well?
Yeah, so in the medical world, we call those paresthesias. It's a sensation of kind of a painful tingling, almost as if like you've, hit your funny bone and have a little tingle on your elbow and in your hands, or like if a part of your body's falling asleep and it's kind of a weird sensation. But it can be, again, this is where we would want to assess, do a good physical exam, see if it's accompanied by numbness, see if it's bilateral, see if it's in the hands or the feet, or if it's in another distribution that may be either kind of diffuse or dermatomal. All of these would help us assess the functioning of the nervous system. But what we know about fibromyalgia is that they can have, similarly to those migrating joint and muscle pains, they can get kind of migrating neurologic symptoms, whether it's like a vague tingling or those paresthesias, like I mentioned, or potentially even just kind of like very intermittent migrating numbness has been reported. But I've always stressed this when I see my patients or when we do webinars that fibromyalgia can be a yes and condition, and that we shouldn't ignore those symptoms. And if there is anything concerning for a neurological process or potentially even a vitamin deficiency, there are certain vitamin deficiencies that can lead to paresthesias, numbness and tingling, that we need to be looking up and working up those as well.
Yeah, I agree to those suggestions. And in addition to that, sometimes rarely we also see overlap between small fiber neuropathy and fibromyalgia. So it can present very similarly with diffuse migratory pain along with pins and needles. So it is always important to identify that, and that needs most of the time a skin biopsy to identify small fiber neuropathy. The treatment of both conditions can be similar, but it's still important to, if possible, differentiate between both of those.
I wanted to go back, Dr. Paul, to something you said about how there's no test right now for fibromyalgia. And occasionally we get patients who ask about like the FMA test or tests that claim to be for fibromyalgia. Just wondering if you had any thoughts on those. I know that they're typically not recommended by physicians. And so just wondering why and a little bit about, if you get patients who ask about that as well.
So we do have patients ask about it, and I really wish if there was a test for fibromyalgia we could do. But right now we don't have a test. When the FMA test came out, it gave a lot of hope, but it didn't have enough strength in scientific terms, sensitivity or specificity to diagnose fibromyalgia. And also, most of the insurance didn't cover that. So some patients end up spending thousands of dollars from their pocket for that. So we haven't done that. And those tests were mostly looking at cytokines or proteins in the blood of patients, um, the levels of which seem to be different for patients with fibromyalgia. So that was what the test was based on. And we use some of those kind of tests in other autoimmune conditions. But just that fibromyalgia hasn't proven an autoimmune base yet. So maybe that is why we don't have a test. So it's still a very clinical diagnosis based on the clinical criteria of diffuse pain, fatigue, and cognitive abnormalities. And is there anything else going on? Those kind of situations. And I don't even know if there is anything commercially available. Are you aware of anything?
No, so the FMA was the last one that came about, and I do believe that it's not generally being used anymore. Number one, because it was very poorly covered by insurance, but
Yeah,
you mentioned the very high rates of false negatives and false positives, and how really the panel of what they're looking at is very nonspecific. And I've done other research projects showing that levels of pro-inflammatory cytokines can be elevated in other types of chronic pain conditions. So it's not necessarily pathognomic
specific. Yeah.
specific to fibromyalgia. So, I mean, I'm with you. If there ever becomes a test that allows us to definitively, have this marker that has high specificity and sensitivity, then, I would be all for it. But I would say I feel like the criteria we have, nowadays, the revised criteria from 2016 are very, very good at identifying fibromyalgia. And at least from my standpoint and how I treat it is definitely more of a spectrum disease as opposed to like a, yes, you have it, no, you don't kind of a thing, because, patients on the scale of the fibromyalginess can be anywhere from 0 to 31, and anything higher than 13 is typically a positive fibromyalgia diagnosis. And so patients who have a score of 13, how they present is very different from a patient who has a full score of 31. So I am always treating the patient, um, even if they have a score of 12 or 11, they have some level of centralization going on. So, the scale is great. The diagnosis is great. It definitely empowers patients. But I think really when I'm treating fibromyalgia, I'm focused on how can we, fix these underlying mechanisms that are present, to improve symptoms. The term fibromyalgia is honestly a little, I struggle with it a little bit just because it still, in my opinion, kind of insinuates that the problem is peripheral.
Mm.
Yeah, we did a deep dive just in the history of the term fibromyalgia on the Swing Care site that people can check out. But it's interesting kind of how that has migrated to kind of indicate different parts of the body or kind of different pathophysiology over time. Last question, just as we need to wrap up, kind of looking into the future. I know, Dr. Paul, you mentioned we don't really have evidence today or enough evidence to suggest that there is inflammation going on behind fibromyalgia. But I know that there is kind of always research or sometimes things that come up that people are kind of trying to study that underlying kind of inflammation or if there is any connection. We've also had questions like in our patient community around like neurogenic inflammation. Are there any things that you see kind of going into the future that you're looking at about whether there is a link?
Well, I can just kind of jump in and say, when we talk about inflammation, I think it's important to delineate the differences in inflammation we're talking about when it comes to these peripherally directed inflammations that you see in things like rheumatoid arthritis or lupus or psoriatic arthritis. There is some level of low level central nervous system, or what we call neuroinflammation, which is again more of those cytokine or protein based inflammatory markers. We know those are elevated in patients with chronic pain. And so, at least from our standpoint, when I'm treating fibromyalgia, one of the options we do have for treatment is a drug called low dose naltrexone, which inhibits TLR4, which leads to activation of glial cells. And so if you turn off that pathway, you are able to reduce cytokine production in the central nervous system. And in some patients with fibromyalgia, that can be helpful. And so I always try and help my patients understand that they can have inflammation because a lot of them do report feeling inflamed, but they don't have those typical peripheral markers of
Markers,
inflammation.
yeah.
So most of their inflammation is driven by a central nervous system type inflammation, those cytokines and things like that. And that is a totally different type of inflammation than we see in rheumatic diseases.
Yeah, that's a great distinction. Well, as we wrap up today, I just really appreciate your time here. And just one last question. Is there anything, as a patient's coming into a doctor's office, kind of looking into these different options, anything that you would like recommend that they kind of share with the doctor or that can kind of help the doctor with their diagnosis or treatment?
Some of the great questions patients can ask or pursue is to see what other resources this particular place may offer to you. For example, here we do have a fibromyalgia specific clinic run by the Division of Internal Medicine. So they do offer far more than our own clinic. So that is a resource. Another one is we do have integrative medicine here, so where they can explore other potential pain controlling specialties like acupuncture, even Ayurveda, massage therapist. So that is a great resource. So I think it is important for the patients to ask what else is there to help me with my pain control, so that doctors will be, reminded to share all these resources. So it's important to be patient with your provider and still work with them. For example, I know that we do have a lot of resources to share to patients with chronic pain and fibromyalgia. We don't have a cure, but we do have a lot of resources we can share. So a lot of times I see the frustration. Patients might have gone a lot of places, and your own clinic is one of the resources I do share now for patients who want to explore, more into fibromyalgia treatment. So I think that is my message to patients, to be patient with your provider, work with them, explore the resources, learn about your condition. Learning about your condition and learning about your own body and your own symptoms can be a journey. And like Dr. Chadwick mentioned, people are usually on a spectrum. There are people with a very mild disease and very severe disease, and the approach has to be different for each one of them.
I love what you shared. And I also love that Ohio State University has so many resources there. One of the reasons why we started Swing Care is to make that more available, outside of places where they have a fibromyalgia kind of clinic or treatment center. And so to have those resources available to your patients is amazing. And I also love that message of both patient empowerment, but also that teamwork that happens when you find a provider who is really dedicated to kind of helping step through different options. Unfortunately, like you said, we don't have a cure yet, but having that kind of partnership and relationship can just go so far into finding that personalized solution that really works for you. So I appreciate that. I know we're at the end of our time, but thank you, Dr. Paul. Thank you, Dr. Chadwick, for being here, and look forward to talking next time.
Yeah, thank you for the opportunity. Thanks.
Thank you so much.